A very good evening to all the viewers and listeners of the YouTube channel of Rehabilitation Science Group. And all of us in rehabilitation learn and every day know of what to do for the management of various conditions and pathologies. And today, with this interesting topic of what not to do in stroke rehabilitation, we have with us Dr. Partha Komineni. Dr. Partha is the Chief of Neuro Rehabilitation Services at Ramaya Memorial Hospital in Bengaluru and is also the founder of POS Rehab LLP. Dr. Partha is also an MPT in neurology with vast experience, and I hope that the best moments of his experience across these 2 decades will be shared today with us. We welcome you, Dr. Partha, and you may please continue now.
Thank you, Dr. Harpreet. And I thank the Rehab Science Group for giving me this opportunity to talk on this topic of interest, which is what not to do in stroke rehabilitation. So it was of interest that it is important for us to really look into some of the things like what generally happens. Sometimes they may not be of great interest in the recovery of the patient population. So we all thought that it might be of some use and importance in the rehabilitation process to know at least some components that may not be very useful in stroke rehabilitation. So we thought it would be useful to the clinicians who day in and out deal with stroke patients. I hope our efforts would be of some use to our listeners and fellow clinicians, right? So that might help them at least take some 3 to 4 key points that would influence the rehabilitation program of the stroke population. Right? So the contents would be introducing, then what is the role of physiotherapist? We'll be briefly touching on that. Remembering the goals of rehabilitation, we'll touch on the principles in neuro rehabilitation, and then what not to do in stroke rehabilitation. The first 4 points would go on for say 5 to 6 minutes or so, and the later on would be main focus is on what not to do in stroke rehabilitation. All right. So why this topic and its relevance? So we thought it is really important. Personally recall the mistakes and my experiences of what we have done to the patient population when we began our career, right? So we all have great intent to help the patient population, to help them recover as fast as we can. And some of us really struggle, put in all our heart to help the patient. But in this process, there are some situations and times where the process, some of the areas we might do things wrong. For those who are doing it little differently or can be done more differently, so this topic would help. So the intention is not to tell that we are doing all the right and the best of the things. The intention is only to share our experiences, how we may avoid those things that may not really be effective in the recovery process. That's the intent of the discussion or the talk. Right. So now let us understand what is the role of a physiotherapist. So we're all physiotherapists, right? So there might be some physiotherapists who or non-physiotherapists who will be listening as well, right? Even for them, the role of a physiotherapist is to get the patient function well. I have this picture in here, which is the Virat Kohli trying to hit the ball, or he's hitting the ball, right? So he is functioning well, right? We all understand that for any human to do this kind of an activity, right? What is required to function well? To function well, The individual, within the individual, it is not just the muscles and the bones and the nervous system alone that functions together to bring about the movement. There are various systems within the body which have to work in a coordinated manner, right? That is within the individual, the various systems have to work in collective manner, right? So apart from the individual, what influences the function or a movement? The individual has to interact with the environment. So here, our player is trying to hit the ball in the environment. He is the individual. He has to interact with the environment. Within the environment, he has to do that activity, the task. The task here is to hit the ball. So for the function here is to hit the ball well. To hit the ball well, what should happen well? The individual should interact with the environment and the task that he intends to do so that the function is accomplished. So, for any person to do a normal movement, we need to have good interaction of all of these things, right? So, and our role is again to regain near normal movement, right? If we all know that we have to get the patient to achieve normal movement. So, what is it that we need to know if you have to get the patient to achieve his normal movement? So, we need to know what is normal movement. Only when we understand what is normal movement will we be in a position to get them to do a normal movement, right? We all study what is normal kinematics and kinetics in our first year biomechanics. If you have done that part really well, the subsequent phases of our learning and experiences will become easier. So the best simple example of normal movement for one activity is walking. So for walking, gait training, we all day in and out work on gait training. So if you have to get the patient to walk well, what should we understand first? We should know what is normal gait cycle. What is normal gait? How does a normal individual walk? So only when we know how to walk, how a normal movement happens while walking, then only we can help a patient walk better. So similarly, for every activity, there is a normal biomechanics, right? There is no stereotype normal movement. There will be lots of variety of movements that can happen while doing one single activity, right? So, but we need to understand the biomechanics right? Only then we can help the patient achieve his movement or function. I'm just trying to introduce these topics because these are important to even understand what not to do in stroke rehabilitation. And other thing that we need to remember is the goals of rehabilitation. Once we start treating the patient, many of the times, even with lots of experience, we tend to set right goals for the patient. When we don't set the right goals, we miss on achieving what we intend to do, right? You need to know where you have to go, where you have to reach. Only then will you be able to achieve that, right? So when you're treating a patient, we need to identify what is it that you have to achieve in the patient. Only then will you get there, right? So there is a high chance that we miss to set the goals. We may believe that I have set the goals to all my patients, but the chance is really, really high. We need to reflect on ourselves. Even I miss sometimes, not that I'm so big in rehab and stuff like that. In spite of working with them for a very, very long time, there is a great chance that we miss to set the appropriate and relevant goals to the patient population. So when it is set, we tend to ignore or forget it subconsciously. Sometimes we all want to do it good, right? So, but when we set goals, later on after some time, what happens is we unknowingly ignore or forget them and then continue to treat the patient. When that thing happens, reaching the goal becomes really, really difficult. You might be achieving some step, but there is great potential between you and the patient that can be achieved if you do not ignore or do not forget what you are working for. So, have it written in bold is what I would say, right? So, please follow the ICF model. that will drive you to treat the patient better, that will help you understand what the patients need, and then you would always work towards that. Once we understand what the patient needs, you would always work for that. Why would we work in a way that what the patient doesn't need, right? Make it more patient-centric rehabilitation, right? To make it more patient-centric rehabilitation, if we all follow the ICF model in setting goals, that would drive us to do the best of our abilities to help the patient population. All right. So some principles in neuro rehabilitation are very important, right? Every principle is so important. I thought we'll just discuss two of them. One is the motor control. Motor control, we all know that it is the ability of an individual to maintain the postures and the movement based on an interaction among the individual task and the environment. We need to remember the first slide in there, Virat Kohli playing a ball, is I was trying to explain the motor control has to be good. That as comes with only the right interaction among the individual, the task, and the environment. Then motor learning. We all feel that when we treat the patient, right, the patient might perform at that point of time. He performs it, just does it well, but the next day he doesn't do that. So we might feel, why is this happening? Right? So that means what? The patient has the ability to do the right things, to achieve the right movement patterns, but he's not able to perform it the next day or few days later. What is missing? What is missing is in the training, we may not be really following many of the principles of motor learning. There are lots of principles of motor learning. Motor learning means what? So if we treat the patient, if the patient is performing today, tomorrow, you should be able to do the same thing after a month or after 2 months, after 3 weeks or 4 weeks, whatever it is, right? That's when we say that he has learned that function, right? For example, if you train the patient to sit to stand, right? Then that day he does it. Maybe after 2 3 days, if you see, or sometimes you see the next day, many of the times, even the next day, or even on the same day, a little later, after he has performed it right with you, he may not be doing it the way that he has performed with you. Why is that? He has not learned it. So we all have faced this. We all face it day in and out. So please go back and we'll have to look into all the principles of motor learning, which will help us make the patient learn the movement right. We'll be training well, but we might miss on following the principles of motor learning. So it is really a challenging scenario to make the patient learn it, but it is a challenge. That is what we are about to do to get the patients better, right? So let us follow the principles of motor learning so that the patient learns the movements right. Right. Next is what not to do in stroke rehabilitation. There are some of the things commonly followed, commonly made, that is observed in the treatment scenarios. We thought we'll just put it across and discuss a bit on that. Okay, one is the use of arm pouch, then repetition of abnormal movements, starting with poor posture, encouraging knee hyperextensions, using static AFO, performing movements that causes shoulder impingements, training high-step gait training, first swing with the weaker leg, gait training, training sit to stand with poor biomechanics, adopting poor posture, I think it's a repetition, misunderstood favorite weight bearing in the upper limb or lower limbs, right? These are some of the things that we thought would be of relevance in here today. So let's begin with use of the arm pouch, right? So of late, in the last few years, we see the use of the arm pouch is really decreased, right? Has come down a lot. Earlier days, the use of arm pouch has been very, very extensive. For very few people who observe or see, it is for those who still believe that use of arm pouch is still a use, right? So we'll discuss on why the use of arm pouch may not help, rather it can affect the patient, right? Right. So what is the reason that the arm pouch is used? It is assumed that it will help prevent the subluxation of the shoulder and it will reduce the pain in the shoulder, right? It might to some extent prevent the inferior translation of the humerus and the entire upper limb, right? But if it is not fixed well, many of the times it won't be fixed well, but still the translation continues to happen and the traction on these tissues will be there. But what is it really helping? It does not really help prevent the subluxation, right? And what are the negative effects of using the arm pouch? What happens is the patient is not sometimes is not aware of their upper limb. So what we are doing is we are not allowing the use of the entire upper limb. When we don't allow it to use, then it goes for disuse and it is forgotten kind of a thing. So when we constrain the entire upper limb movement, the affected upper limb movement, then the opportunity for him to feel and use the right upper limb will be minimized to a great extent. And also it will cause lots of deformities, right? It will not allow the elbow to go into flexions, the biceps muscle will go into a lot of tightness, the forearm goes into pronation, the tightness becomes even more in there, the finger and wrist flexors go into a lot of tightness as well, along with the hypertonicity because of neural mechanisms also will contribute more shortening of all of these structures, which in turn will limit or cause lots of constraints in making this limb functional. So there are alternative methods that can be used. One is the arm support, which will help the humerus stay a little higher up, like now in the glenoid cavity, right? Which can go around the shoulders, and you can hold it there. The entire limb is free for the movement or exercise or training purposes. So that can be another alternative. So the arm pouch will limit and constrain the use of the weaker limb. So the so-called reduction in shoulder pain and subluxation will not be achieved with the use of the arm pouch. Next is adapting poor postures, right? Right, adapting poor postures. We all have seen, like most of the times, the patients will be slouched down forwards like this. They will be down in like this, right? Right. So what happens is when they tend to be in that postures for very long times, what happens is, as we all know, that there is a lot of shortness. Suppose if the patient is going in down like this, the anterior structures will become tight and the posterior ones will be elongated. The muscles are not really firing in well. And then when you bend to the sides, there's a lot of flexion and stuff like that. So most of the patients, their patients are sitting in a wheelchair or sitting on a normal sofa or on a cot. So the tendency of them to adopt poor posture is really great. So what would happen if they continuously adopt poor postures? So if possible, those who are live, all right, we all know that, just a reiteration of that. When we have a poor postures like this, right, when we ask anyone, if I try to raise my hand up, I can only go this much. But our intention is to make the person raise the hand fully up, right? Right. So with poor postures like this, the elevation ability is only till this much. This is my normal hand. I don't have a problem as of now, right? So I can only raise it this much, right? So when we try and do the treatment in wrong postures, or if they assume in these postures long time, it becomes difficult to treat them, right? So it's always advised to get them into the right postures before you get them to do any activity. So when they're sitting in like this, the muscles are not working. What are the muscles that are required to keep a person sit straight? We need to have work on back extensors, the core muscles, and there should be core contraction of other muscles. We all know that, right? They have to work. When you are in slouched postures, right, the muscles are not really working. It's only the ligaments and the other fascia and soft tissue, non-contractile elements that are maintaining your posture, these things. The muscles do not really work at all. The muscles forget what the kind of job that they are supposed to do, right? So this posture will minimize, adopting these postures for a long time will cause lots of problems in the subsequent phases of rehabilitation, right? Then starting the movements with the treatment with the poor postures. When they learn to achieve that posture, they don't know how to go straight. So sometimes what happens is we tend to start treating the patient in sitting in poor posture. Let's say, for example, the patient is sitting in like this. We want them to work on this weaker upper limb, right? When you make them to work with the weaker upper limbs, what happens is we already observed that we cannot really lift it up beyond. And with this posture, even you cannot really turn, right? But when we try to make them do these movements in poor postures, we cannot really achieve what we intend to achieve. Suppose we want to say that we're working on the trunk control and dynamic trunk control, right? So when we ask the patient sit in poor posture and we ask him to turn to the sides like that, because we want to achieve, we want to make the muscles fire really well. What happens is the abnormal postures will not allow you to do the complete range of movements. The upper limbs cannot really do to their capacities, even the trunk also does not work well. So get them to achieve first the right posture, get them to achieve the right alignment. In your first years or second years, we all have learned starting positions and then the derived positions. The starting position is good, the subsequent phases will be right. The foundation of a building is good, the next structures would go right, right? So the starting posture, starting point is wrong. Starting position is wrong. Subsequent are the derived movements will definitely go wrong. Ensure the starting point is right. Then the subsequent ones can become good. If the starting point is wrong, whatever you try to build on from there will always be having lots of constraints, right? Please remember, in standing or sitting or in lying, whatever it is, ensure the starting posture is right. Is very, very, very important, right? Yep. Okay. Next, performing movements that causes shoulder impingements, right? So, uh, this is, I thought it is really important. Most of the patients come with shoulder impingements. It can be induced impingements, or sometimes it could be an impingement that comes because of poor biomechanics. So I was using the term induced, right? Uh, I have a reason to say that. So while we are treating a patient, let's say in the ICU or in the wards or at home or wherever, right? If you have do complete elevations with the internal rotations, what happens? There is sometimes the tendency is we tell the patient's party to do the movements as many times as possible, in the 100 times, 200 times. We all love the numbers, hundreds, tens, and stuff like that. So when we tell them, and sometimes when we do it in the wrong direction, poor biomechanics with internal rotation like that, what happens is greater tubercle goes and hits the coracoacromial arch repeatedly. What happens is supraspinatus gets impinged, right? This is normal biomechanics. We all know that from the first year biomechanics, but we tend to ignore some of those knowledges when it comes to the practical implementation of that. So we advise, this is one simple example, while doing the passive movements or active assisted movements, ensure that it is not in internal rotation. And sometimes we tell the patients to do the movements many times, right? Repeat. Let's say, for example, now is the thing, functional movements. Let's say I want the patient to pick some object 100 times a day like that. Every time he tries to lift, like that, and goes. With every time he is hitting the head, like no, the supraspinatus tendon, the incision, the tendon is hitting the coracoacromial arch. We do it more and more times. The wrong movements are repeated many times. And there are many other reasons why the impingements happen. So it can be avoided very well. If you know what is normal biomechanics, if we all follow what we know, how a normal movement takes place, the chance for the impingement to happen will be taken away completely, right? So please remember that we need to avoid movements that causes impingements. So uh, there is great success when we follow the right biomechanics. At my center now, we don't see any impediments at all. So because we have learned it the hard way to avoid those impingements, right? So that's why I was telling induced impingements can be avoided, right? By understanding the normal biomechanics and training them in the right directions. Misunderstood favorite weight bearing postures. So every physiotherapist, one or the other one or the other time in life, they would have. There are some people who don't believe in it at all. Some people would want to do that. Sometimes, at any given point of time, what I was telling was they would always go with weight bearing to strengthen, to recruit, to sensory stimulations and all of that stuff. I thought I'll just demonstrate, and that's why I was moving the camera in this position to show you the weight bearing positions. So the reason for weight bearing, what some of us believe is that it causes sensory stimulus, reflex hierarchical models, which is does not really influence the recovery of the patients now. But let us not go into that various theories of motor control. We'll restrict to only how the weight bearing has to be done. If the weight bearing is done in locked position, if we lock the elbow and then weight bear, you all may try now, right? So in locked position, if we weight bear, the muscles are not working at all because it is locked. When the elbow is locked, you have attained some stability. The stability is achieved because of the articulating surface structures in the closed kinematic positions. Okay, it is completely closed. You don't need muscles to really work to maintain that, right? What is your objective in weight bearing? Your objective is to recruit the muscles of the scapula. Sorry, guys. Yeah, the objective is to recruit the muscles of the scapula, muscles around the shoulder, work on triceps and biceps co-contractions, and some of the forearm muscles, right? If the intention is that, if you lock it, it is passively locked. Passively, the posture is achieved. It is similar to attaining sitting posture, sitting like this. You are in a locked position. Like, no, you are, in the sense, you are passively fully flexed. The muscles don't have to work to maintain this posture. Similarly, if you weight bear in the locked positions, the muscles will not work. You attain some stability, which is of uh, poor consequence, right? It won't get you what you intend to. Your intention is to recruit the muscles, right? The other problems that happens with locked weight bearing is the humeral head is going and heading around the coracoacromial arch, causing more problems at the shoulder joint, right? So the best position is keep it soft, keep the elbow soft, allow the muscles, the body to respond to maintain the posture. You are giving some opportunity for the muscles to work. If you lock it, there is no chance. You're taking away the opportunity for the muscles to fire. But when you keep it in a soft position, you are allowing them to work, right? If your intention is that, okay? If your intention is to recruit muscles, this is the way. If your intention is something else, I'm not sure what to expect from that, right? So if you're, whatever reasons you are doing it, if you're doing it like this, I don't think we can get what we intend to. We can cause problems, and the patient will only learn and lean onto this side, causing more problems, not getting what you intend to. All right. So always weight bearing positions, let it be in little uh, unlocked positions, right? With the 5-degree flexion or 10-degree flexion, later on you can increase the flexion and then go into little extension. So we'll have more recruitment patterns. That's the different treatment strategies, which everybody has their way. That 100 ways, 1,000 ways might be there. But the point here is Do not allow the joints to get locked. Do not allow the elbow to get locked. You won't get what you want to. And you would always, I'm repeating it again, don't mind that. Okay, you would again cause impingement at the supraspinatus, impingement in the shoulder joint, right? Okay, right. And the repetition of abnormal movements, right? So whatever we do is what the brain learns. Whatever you do, there is neuroplasticity happening. You do the right thing, there is neuroplasticity happening. You do the wrong thing, the neuroplasticity happens, right? We all know that. Brain doesn't know what to learn. Whatever you give is what it understands and it registers. You do the wrong movement, it will learn the wrong movement very conveniently because that's the easy one and it is done so many times. So, more the neuroplasticity for whatever you teach is getting stronger and stronger. That will in turn facilitate a strong motor learning pattern. Then that's how the person learns. We all have some patterns of doing of some works, right? You would have learned it very strongly. So it becomes difficult for us to come out of that. Bad things is easy to learn, right? Similarly, when a stroke patient comes into us, from the beginning, if you get them to do the close to near normal movements, the learning becomes better, right? So when you repeat the abnormal movements more and more, there is great neuroplasticity happening and then great motor learning for that, right? Our intent is to get the patient close to near normal, right? So find ways to treat the patient functionally towards the normal movements. Suppose we metal, more the repetition, better the motor learning. Yes, perfect. We all know that. If you try to lift the hand like this, we tell them we are happy that he's able to raise it up this, but the patient party family is so excited. My family, like no father, brother, mother, sister, whoever is the patient, right? They're able to lift the limb up so much. Let us make them do more and more of that. If you make them do more and more of these things, what happens? The hand is going like this and you're lifting it like this, okay, 100 times. What are you creating? What is the plasticity doing? It is making the person learn this too much. So avoid the repetition of abnormal movements. Get them to learn the right thing as much as possible. Repeat the right things more and more. That will definitely help you. Make it more functional and the right biomechanics, the repetition will definitely help. Repeating the wrong movements would not get you what you want to where you want to go, right? So that will lead to more other complications and then we'll start treating those problems again, right? And then we try to break that things, let us not get him to do like that, let him get to the normal and stuff like that. So it's better from the beginning, avoid the repetition of abnormal movements is one of the key points, right? Yeah. Training sit to stand with poor biomechanics, right? We all work, everyone works to make the patient. I don't know, I don't know if you can see me completely. Well, I'll just position myself. Okay, not good enough. Okay. Okay. You don't see my face. I think that's okay. You can see my feet. Not still. I move my table further. Okay. Right. All right. We all want the patient to stand up, right? We want them to stand up well. So while training, we'll talk about only a couple of points in here, right? Or 2 or 3 maximum with this biomechanics of sit to stand. When we make the patient stand, what generally happens, not every time, I'm not saying that everybody does that. Sometimes it happens, is we try to block the knee. Somebody sitting in front in there, holding the knee there to make them stand up, right? When we lock the knee, what happens? The patient finds it very, very difficult to stand up, right? In normal standing, if you observe my knees now, if I try to stand normally, okay, the knees are going forward and then coming up, right? So the knees are going forward first and then coming up. So while training, don't have a model, I'm so sorry about that, right? While training, the patient sits in front, locks the patient's knee with his knee or with his hand, and then asks him to get up. So what is missing here? What is missing is the translation of your thigh anteriorly is missing, which is normally required for standing. So please find ways to allow the femur to go forward. The knee has to go forward to stand up. If we stop it, we don't get the normal biomechanics. When the normal biomechanics is disturbed, the whole function of standing is disturbed. All right, that's one thing. The other one is the patient may be in slouched position, right? Anything that you begin in the wrong posture, wrong position, the later ones would be difficult. So unless you get the patient straight, you will find great difficulty in getting the patient stand. The patient is sitting slouched like this. What is happening to line of gravity in COG? It's going more and more posterior, right? Right? It's very, very difficult to get the patient forwards, right? So if you get the patient straight in there, the muscles are ready, the muscles are really active in right postures. Here the muscles are really relaxed and sleeping because you don't get what you want to. They're not ready to work, right? So get them straight and then get them to lean forward before you get up, right? Right, not in these slouch positions, right? And other thing is the feet. If you keep the feet 1 foot in front, the weaker limb in front, and then we do not make this muscle work, this limb work at all. Get them to keep it slightly, the heel should be slightly behind the knee level. If it is anterior to the knee level, you find it difficult. The patient stands up, only turns to this right side, and then he will get up. Is that what we want? No, we don't want that to happen, right? So always get the heel slightly behind the knee and teach them to lean forward and then get up. Okay, so that's the two things. The other one is when you lean forward, ask them to raise the pelvis up first before straightening the trunk. This most of the times we all get it right. Okay, the key point I wanted to tell you was allow the knee to go forwards is the most important one. Otherwise, most of the times we all do it rightly. Right. And encouraging knee hyperextensions. What happens is when the patient starts to learn standing, we all make the patient stand, and majority of the times, many of the times I see that we make the patient stand and the knee is pushed into locked positions. The patient stands for longer times. What is happening in here again? Like we talked about weight bearing sitting in the upper limb. Even here, the patient is weight bearing in the lower limbs, but at the cost of knee going into hyperextension. So you'll be we'll tell that stand for 100 seconds, 200 seconds, 1 minute, 2 minutes, like that. What is the objective? To make the muscles work, to make the movement, the function, the posture be maintained well. The posture is maintained well when the joints are loaded less, right? When we allow the knee hyperextension to happen and the muscles don't work here as well. The joint is in locked position, the muscles will not work because stability is achieved. You all can stand up and then check it out. In the knee in hyperextended positions, the muscles, there is hardly any co-contraction of your hands and quads, right? It's all passive. Your glutes and medius, glute medius and maximus do not fire as well. But our objective is to make them work, to maintain that posture right. So when we treat the patient, ensure that the alignment is right. When the alignments are right, and you understand, we all know what is normal standing, get them to do normal standing, then we are getting where we want to. So please do not encourage the knee hyperextensions. The patient is standing, it is functional and meaningful, but at the cost of stress onto the joint and the ligaments. It will facilitate early degeneration of the joint and too much load, tensile forces on the ligaments. They will give up at some point of time. And the actual goals of recruiting the muscles to make the muscles work in the right postures, static and dynamic postures, is not achieved. So let us learn it initially. It's only a few days that we know that this is how we need to do it. This is how we need to do it, and this is not what we're supposed to do. If you know that, we'll find the right way. If you know that this shouldn't be done, we'll always find what should be done. There can be 1,000 ways of doing it. You can find your own way, your own solutions, right? So we know why the knee hyperextension should not be facilitated. It will cause early degeneration and cause lots of trauma to the other structures of the knee joints, right? Soft tissue like meniscus and the ligaments and all of that stuff. And you don't get what you intend to achieve, right? So avoid the knee hyperextensions, right? Okay, next is the gait cycle, right? We all want to make the patients walk, right? As early as feasible, as early as possible, right? So uh, this is my observation, and many of the physiotherapists follow it, right? So I'll try and explain what we intend to say here is first, swing with weaker leg might cause more challenges, right? So I'll explain you why, right? So I'll stand up for that and then I'll try to explain why swing with the weaker leg may not be the good option, right? I'm not saying that it shouldn't be done at all. We always want it to happen as well in the future. Please do not take it that way, all right? We need to make both the limbs work equally, of course, right? But when you start out, when you're doing the initial phases and the mid phases of gait training, if you do the swing on the weaker side, we might land up with more challenges, but we need to minimize the challenges and get the function done, right? So I'll stand up to explain uh, why swing with the weaker leg may not be great. Okay. Right. Okay. We all see from my pelvis till the feet, I suppose, with this angle. Right. I think yes. Right. Okay. Uh, Let us take left as the reference. Left is the weaker or the hemiparetic limb or hemiplegic limb. Majority of the times, the patient tries to lift this leg up. And in that process, what happens is the patient lifts. I'm not saying that every patient lifts it like this only. Okay, some of them do lift it like that, and majority of the components will be like this, right? Most of the patients, I mean to say, right? So they always wants to do this weaker leg as a swing first to start gait cycle because they can stand well on the better leg. Okay, right? So the stability is good. So they always start with the weaker limb. When you try to do this, what happens is they try to lift it like this. When you lift it like this, what is happening is you're landing in forefoot, and then forefoot to hind foot is the loading response, and then the knee goes into hyperextensions, right? And then again, to initiate hip and knee flexion, that needs a lot of coordination. Okay, the biggest problem is we cannot make all the systems work very well. That is the biggest challenge that we're facing. Right? In order to, the difficulty to lift, to do hip flexion and knee flexion, right, is immense and great, and it needs lots of coordination. So they will not be able to do that. So what happens is the hip is elevated up, hip hiking happens, and then they swing it, right? The circumdactory gait comes into play, right? And then what happens once this leg goes in front like this? Okay, you're lifting like this, and then you go in there. One of the patterns is this. This is not the only pattern. I'm repeating that part again here, right? So once after landing, what is happening is the knee is going into forefoot, loading response, forefoot, hind foot, most of the times, or many other mechanisms also will be there. then that will lead to knee hyperextension. The patient tends to lean forward here, and then this comes here like this, right? And then lifts like this, goes, right? Right, right? So that's easier for the patient to do. So they do it like that. So in that phase, both swing phase is going wrong and the stance also is going wrong. I hope we all accept that, right? So to control that, what might be more useful, and I find it more useful, and my team finds it very useful as well. All right. So you teach them how to stand properly. Begin this stance phase of the weaker limb first. Make them work on that and get the swing of the better leg. When the better leg can do it easily, get has the coordination well, and we are there to support this limb, right? We'll be training with them how to maintain that mid stance, right standing posture well, right? So when we get them to stand well, and we have worked on it before, weight bearing and all of various forms of exercise programs, functional programs, right? When we are implementing that, and you support this limb, right, properly, appropriately, wherever you feel appropriate to maintain the right alignment, get them to do this limb, right? Take this better leg swing first than the weaker one. When this goes well, achieving stance phase becomes easier on the weaker leg, right? Because you are there to support them. The patient learns it if you practice more and more number of times. When this goes in there, the swing becomes easier. We can help them drop the knee and then go forwards. It becomes more easier, right? So the simple point is you might get better benefits. You'll get better benefits if you avoid swing phase of the weaker or hemiparetic limb first, right? So later on, we would want them to achieve that as well, right? But we got to learn things right from the beginning. Get them to do things that are close to near normal movements. Then learning becomes easier. But if he learns the swing first, and more number of times he walks like that, because it's easier and he can do it well, that causes a lot of load on the knee joint, poor biomechanics, poor trunk control, lots of secondary complications or secondary manifestations will appear. So to avoid that, if we can try this swing on the other leg, rather we can better say like this: start with stance phase on the weaker leg. Swing becomes easier, right? To follow through is the swing phase. When the stance goes right, swing becomes easier. When the swing starts with poor biomechanics, the stance also goes wrong. To maintain stance phase is easier. Begin the right biomechanics, derived positions also. Uh, starting position, we all work well. Then derived positions. From standing, the next derived is loading response, mid stance to terminal stance. If it goes well, then the pre-swing becomes better, right? So stance phase, starting position and derived positions can be achieved well. Then the subsequent swing phase can be also achieved well. So please avoid my suggestion. It's not that you have to do it this way. You have 100 ways of doing it probably. So the first swing with weaker leg can be avoided for the benefits that we just discussed now while we are doing the gait training, right? Yep. Okay, training with high step gait training, right? So we all believe that we need to lift our limbs so much to walk. Okay, I think in normal gait cycle, if we all have observed during all our years of learning and experience of treating the patients. First, we need to look at a normal person walking. So the ground clearance while walking on a normal surface is hardly anything. It's only half an inch or 1 inch is all that the foot is off the ground. That's all, right? So but when we train the patients, but we have that some kind of feeling or opinions that we need to train them to lift their limb high up and then walk. The reasons can be many, but the thought is that, so we need to keep in our minds that it's only that the patient has to clear their foot off the ground so that they can go forward, right? So uh, there are many other, there can be many other ways. Everybody can find their ways. I think high step gait training may not be necessary to always practice it too seriously when we are training the gait of a stroke patient, right? The normal clearance from the ground for a person is only half an inch to 1 inch. Maybe there is because of poor dorsiflexor control, we might want to train them differently. Okay, so but when we begin with the stance phase of the weaker leg and then the follow swing phase, then that problem also can be resolved greatly. But we need to practice it and learn it well so that we get it going right. But in that process, we teach them to lift the leg up too much. The whole biomechanics changes many of the times, not all the times. Many times is key here, right? So please understand the normal clearance from the ground and how do you get the normal biomechanics without really lifting the limb. When the patient is focusing and the therapist is focusing too much on lifting the leg up every time, we are missing many pieces of the normal biomechanics. We focus only on lifting it, clearing it, but we are, I can say, okay, no ambiguity in here, we are definitely missing on many pieces, many biomechanical aspects of the gait cycle and the swing phase as well. So please find other ways. I'm not saying that you need to drag the forefoot and then drag the toes on the ground. We have to find various mechanisms to get them to train in the normal gait cycle, close to normal gait cycle. There are various methods. We all can find our own ways of training the patient. Right. Next is the static AFO, right? I think here again, I think this is my last slide in here. Uh, Things are changing. We are avoiding AFOs to a great extent. That is a good sign. Without using AFOs, we are getting good gait cycles and better biomechanic movement patterns. We are achieving all of that, right? Still, there are sometimes we see patients when we see them first time, they come with AFOs, right? Especially with rigid AFOs, the static AFOs, which will influence the biomechanics go wrong. We'll just discuss, we'll spend a minute or two on that, right? I think I'll stand up again to show the biomechanics of gait, biomechanics of the ankle joint while we walk, right? Okay. Right. So let's say we are standing in here, right? Left is the reference leg. Okay. When we take the right leg forward, what is happening at the ankle joint on the left leg? The left ankle is going into reverse dorsiflexion, right? That's normal biomechanics, right? So let's see here, initial contact, loading response, mid stance. What is happening? There is a lot of changes happening at the ankle joint. Initial contact for foot, there is plantar flexion that's happening. Then from there, we have the reverse dorsiflexion is happening till mid stance. From there, reverse dorsiflexion continues, right? More it goes into reverse dorsiflexion, tibia is going more anteriorly, and then again foot is going into from mid stance to terminal stance to pre-swing. Again the ankle is going into plantar flexion. So we need to have free ankle joint for the right biomechanics. So when you have a rigid AFO and rigid ankle, what happens? You go like that, then the patient goes like that, right? From the mid stance, what is happening? The patient can go only like this. The patient cannot get the leg into terminal stance. From mid stance, he's maintaining mid stance, and the ankle does not go into reverse dorsiflexion. What happens? This limb goes off like that. So there is a lot of compromise. If you see my hip, you'll understand it better, right? I hope you saw the ankle is there, right? When you are not allowing the reverse dorsiflexion there, what happens is you go like this. The hip comes into flexion if this leg is going forward. Otherwise, what happens is the leg is there here, and then this leg comes only here. It does not go forward. the step length is decreased, the stride length is decreased to be smaller, right? So I think we got, I shared that simple point why we need to have ankle joint working well. For that matter, every joint needs to move well, right? If you don't allow the movement to happen, the kinematics to happen, it can be the ankle, it can be the knee joint, and it can be the hip, right? We aren't disturbing the biomechanics, right? Unless we need to protect it, protect something, we need not uh, constrain the movement happening at those joints. So it's always better find ways to allow the movements to happen as much as possible in the normal kinematic way so that we get what we want, so that we help the patients achieve their goals, right? Yeah, I think that's the simple information that I wanted to share on AFO, right? And I think that's it with respect to some of the things that may not be very beneficial in the treatment of stroke patients, right? Thank you so much.
Thank you, Partha, for being with us and sharing this wonderful information. And Partha, although I was hoping that there would not be more than 3 or 4 things that we should not do, but there's a long list, and I think experience tells it that many people still prefer to use those methods as learned methods, and hard to give them away. But I think there is a time that you need to unlearn also and start knowing what not to do. So when we are talking about doing something special or doing something advanced, now all the things that we don't have to do not come under any special or advanced category. So when you were explaining, so all these are very basic stuff, very easy to follow, and easy to implement at the level of clinic. I think that ease of being applicable makes them very easy to be done by multiple clinics and multiple setups. So I think, what do you say, Partha? Is it that because they do not require extensive training, they are so easy and convenient to follow that they become a part of the routine?
Yes. Yeah, it when we start treating, we all have our own challenges. We have lots of jobs to do. So when we start treating, we get so used, as you said, like no, we don't reflect what is happening. It becomes very convenient for us to continue to do what we are doing because the patients do recover to some extent, definitely yes.
Right.
But with some small modifications, we can really influence the recovery to a great extent. But these small changes require a lot of attention, patience, and understanding of normal biomechanics.
Yes.
And one of the biggest problems, challenges in neuro rehabilitation, as we all know, is accepting or listening to what others tell. We all have strong feelings that this is the thing type. Even I've gone through that phase many years back, right?
Right.
So it is difficult, but if you want to do good, we will accept that there is a lot that we don't know, there is only little we know, right? So talk to our peers, learn from our patients, think of what is normal movement, then we will accept that there is a lot that we need to know. So coming out of the comfort zone and doing this regularly, commonly practiced mistakes is the biggest challenge, but we all can get there.
Yes. So before changing your patient, I think there is a need to change the practice that we do. And I think this lecture takes us in the right direction of doing what not to do in stroke rehabilitation. Thank you, and a very good evening to all the listeners.
Thank you.